This is a VR 360 video. Okay, you can see the entire OT if you turn your head. And now we have started the endoscopic mode of vNOTES. So first thing that you will see is the cervix. Okay, now I've held the cervix. What we can see is the open anterior pouch. Okay, so camera goes inside. Okay, we confirm that there are no adhesions over here and the bowel is behind. Okay, so what we can do is we can begin our surgery. Magaya. The first thing is that we hold the cervix, and we can use the cervix as a steering wheel. So first I will deflect the cervix to the opposite side, and you can even watch my movements outside. बाहर के लाइट लगाओ इधर पीछे के, ये trocars and ports दिखने चाहिए. Right, this is fine. So you can see the movements of my instruments outside in the glove port, and as well as you can see the screen. So what I have done is I have deflected the cervix to the opposite side, and my instruments are crossing here, and ligashore is coming below the note sync grasper. Note sync grasper has been connected to the smoke evacuator. So the smoke is continuously being evacuated by the smoke evacuator through the note sync device. And this is the posterior leaf of broad ligament that we are dissecting on the right side, so that we can further isolate the uterine vessels. एकदा क्लीन करा. Okay. हे पकड़. Three-way. Three-way. Okay. Increase the flow rate of smoke evacuator. Yeah. Okay. So again, in similar way, I will dissect the anterior leaf of broad ligament over here. What's the screen? So whenever we go from below, the first thing that we will see is the veins. Okay, first we will see always the uterine veins. So I'm sealing the uterine veins first. I will divide the veins first, and then we'll go for the uterine artery. Okay, so I have divided the vein here. Again, I will keep dissecting medial to the uterine artery. So that I can dissect out the uterine vessels from the body of the uterus. This will apparently increase, this will actually increase the length of uterine vessel that is available for sealing. You can see here, this is the uterine artery, and I am yet to seal it and yet to divide it. But before that, what I have done is I have increased the length of the uterine artery by dissecting it out of the body of uterus. This is surgical augmentation of the length of the uterine. Now, since I have got a significant length of the uterine vessel, you can see here, now I will seal the uterine vessel at multiple places before I divide it. So this is my first seal. Since I have got a good length, I will go further laterally. And now here I will divide. Here I will finally divide the uterine artery. Okay, now here I can see here a few adhesions of ovary that will deal later on. First we'll go to the opposite side. So again, I'll change the grip of the cervix to the opposite lip of the cervix, so that when I deflect it, I can see the pedicles on the left hand side. Again, here I expect the veins first. Please also observe my movements that I'm doing outside of the instruments. And you can superimpose your hands on my surgical movements so that you can get a feel of it. So that is some vein. So that is the uterine artery. Of left side. So only disadvantage of this technique of trying to increase the length of uterine artery is that sometimes you have to dig into the uterus and there can be specimen side bleeding. Okay. Now again here I have a significant length of uterine artery on the left side, so I will seal it at multiple places. generally I don't use the atrium technique till I have divided bilateral uterine vessels, and since I like to use atrium technique more mainly for the coronal pedicles. So this is where I'll divide the left uterine vessels after sealing it at multiple places. Okay. So now what we can do is can insert this note sync device into the cervix, going into the cavity. Inside the cavity, I'm opening the device so that when I push it, it does not perforate. Look at the way I'm holding the note sync device to get an excellent visualization. Okay, we can deal with these adhesions right now. Okay, yes. So I'll just change the ligature for a bowel grasper so that I can push that loop of small bowel behind. We are operating at the pressure of 10 as soon as, and this entire surgery is being done at the pressure of 10 mm of Hg with continuous smoke evacuation. So effective pressure inside the abdomen and is actually less than 10. Okay. So I have just pushed the bowel behind, and yeah, we'll momentarily increase the head low so that this bowel goes behind. Yeah. Now we can come back and reduce the head low. This is a good opportunity to visualize the ureter here. I suppose this should be the ureter here. This one. This one. This is the ureter. Okay. So this is a patient with adenomyotic uterus. Okay. And her age is 39, so we are conserving the ovaries. So the note sync device is inside the uterus. It is retracting the uterus laterally and lifting it above, away from bowel. And I am getting an excellent exposure of right coronal pedicles here, so that I can divide it sequentially using the ligature. It is always a better idea to use at least 2 seals so that you don't have to come back and revise oozing pedicles later on. And that is the fallopian tube. We'll do the salpingectomy later after we finish this hysterectomy. Okay, so we have completed the hysterectomy on the right side. Now, without taking out the noticing device from the uterus, what I can do is I can simply lift it in this way, and I'm crossing my hands externally, if you can see here. Focus. Yeah. So in similar way, I am having a decent exposure of cornal pedicle on the left side. I'm lifting the entire pedicle and the entire uterus away from bowel. So there is no risk of thermal spread. If you can see the dark spaces above and below the pedicle, which itself means that there are no adhesions and the pedicle is away from all the important structures. So that is the fallopian tube. This is when we remove the noticing device from the uterus. In the meanwhile, the uterus will stay in the abdomen. We clean the noticing device. Clean the ligature. Okay. Grasper. So I can see some adhesions over here. Of fallopian tube, and so there is an element of PID. She also had cervicitis. Okay, so we can also deal with these adhesions right now. So such minor adhesions are not at all a problem for NOTES approach. And we can see the retroperitoneal anatomy here. This is where the ureter is on the left side, and the pulsations of internal iliac artery. And this is where the uterosacral ligament is. So if we have to do a high uterosacral ligament suspension, this is the place where we would do. Okay. Very short bursts of energy. Lift the ovarian adhesion in the air. Okay, and that is, we are done here. So now we can move to salpingectomy. NoteSync device is clean and ready. Okay, so it's a wonderful multi-purpose device which helps in all steps of vNotes, and it's very good because it continuously evacuates the smoke, so gives the clear visibility during all times. So the requirement of cleaning the telescope is very minimal. So the best part of vNotes is that it makes salpingectomy and adnexectomy very easy, which is actually a very challenging part during conventional vaginal surgery. Okay, so the good part of the glove port is that it gives you this reservoir where you can store the specimen before the surgery is over. And similarly, I can go for this tube over here. So the best way to begin salpingectomy is just lift the fimbria and retract it medially in the same plane of IP ligament. You don't have to push it, you don't have to pull it, just medialize it so that you can see the entire mesosalpinx very clearly. Okay, so even this tube comes out. And now we will check the hemostasis before removing the uterus. That is our friend appendix saying hello. So I think we are happy with the hemostasis. And this is the lip of the cervix. So I'll switch the ligature with suction so that I can remove that 1 ml of blood that has been spilled inside. As well as I'll ask my team to stop CO2 and start the suction so that we can completely remove the CO2 from the abdomen. This is a very important step to evacuate entire insufflation. Stop CO2, starts suction. Okay, and as I do that, I'll remove the uterus. Stop recording.